Thanks, everybody. And I would like to invite our three representatives of our Accelerator organizations who are going to share some of the initiatives that they have been part of. Welcome. So in a few moments, after a few introductory remarks, they will share their initiatives and the advances. So thank you, Amy Locke. Thank you, Jerry Abraham. And thank you, Lori Hamama. So it's really an honor for me to serve as a coach for the National Academy of Medicine's Change Maker campaign for health worker well-being, and I'm really thrilled to be part of this celebratory event. And again, I want to share some of the overview of what this program has been accomplishing. So for the past year, accelerators, representatives of the Accelerator organizations, and the coaches have been meeting on a regular basis, on a monthly basis. And during this time, the representatives, the coaches, we all talked about the initiatives that have been happening in the various organizations. We talked about the progress, which initiative, which priority, but also what went well, what was challenging, and what solutions, and how we can help accelerate each other and support each other towards moving health professional well-being forward. And I have to tell you, at the end of each of these meetings, each of these monthly meetings, I always felt personally hopeful and invigorated about how we were moving forward. But one important part of documenting this program has been for our Accelerator organizations to delineate on a dashboard created by the National Academy of Medicine which priority they would address, list their local initiatives, and then regularly update the dashboard about their progress. And as you can imagine, this documentation has been a labor of love. It's led to incredibly rich information about the reality of enacting the NAM priorities and the reality of promoting professional well-being in organizations. So to fully appreciate the wealth of the data before us, under the direction and with the support of the NAM, Dr. Christine Olson, who is also a coach as myself, and I, as well as all of us collaboratively, have begun to work on a formal qualitative analysis of the 412 initiatives. And so now it's my turn to pause and repeat, 412 initiatives that were cataloged by our Accelerator organizations. And in order to analyze this, it involved multiple readings to familiarize ourselves with this, and then we proceeded to create themes to categorize the different initiatives, and then to see how these initiatives that were from the ground up corroborated with the NAM priorities. And what we found thus far is that there was overwhelming corroboration. We also found that there were some priorities that were perhaps a little more easy to implement. And there were also some initiatives that were developed by the accelerators that went beyond some of the NAM priorities. And so we need to understand these differences to better assist organizations. So ultimately, we plan to produce a scholarly report based on this qualitative analysis to delineate the lessons learned about how organizations implement well-being initiative, how they enact the NAM priorities in real life, and also within their own organizational journey, and understand how these journeys and these priorities and these initiatives all interact and work together. We believe that by analyzing this rich data, we will fill, I think, a really important research gap in the field about the reality involved in promoting health workforce well-being in our organizations. So I'd like to now cede the stage to our representatives of 3 Accelerator organizations, and they will share their well-being initiatives, their implementation tactics, their outcomes that they've accomplished so far. So again, we welcome Dr. Lori Hamama, Senior Medical Director of Well-Being at Ohio Health, Dr. Amy Locke, Chief Wellness Officer at University of Utah Health, and Dr. Jerry Abraham, President of the Los Angeles County Medical Association and Director and Chief Vaccinologist, CDU Kedron, Mobile Street Medicine Health. Welcome, and we can't wait to hear what you have to share.
Thank you. Thank you so much. I'm Lori Hamama. I'm the Senior Medical Director at Ohio Health. For those of you who don't know, Ohio Health is a community-based, not-for-profit health system that spans about 2/3 of the state of Ohio. So we serve 55 of the 88 counties. We have 19 hospitals, 300 ambulatory practices, 35,000 providers, associates, physicians, residents. We have 5 teaching hospitals, 40 teaching programs. So we cover a lot of the state. And I've been in this role since 2019 and was hired just before the COVID pandemic kind of accelerated the work, the first acceleration before the second acceleration with the National Academy of Medicine. And we really had a choice to make as a health system of, do we focus kind of narrow and deep on one population, or do we think about the all of Ohio Health? And because of the diversity of our care sites, and where our clinicians practice and the populations that we serve, we have a 12-bed hospital and an 1,000-bed hospital. We really felt it was important to think about a broad program, not boil the ocean, but really think about how well-being impacted the entire health system. So we started small but large and really thought about the structure, and a lot of the work we've done through the National Academy of Medicine has really helped us build a structure that will lead to long-term well-being for the system in a way that we can iterate, that we can scale, and then we can continue to grow as our health system grows. Central Ohio is growing very quickly compared to other regions in the state, so we have to continue to make sure we can provide these programs long-term. So we really focused on 2 areas: mental health, and then institutionalizing well-being as a long-term strategy. So we have a clinical practice that we've scaled and grown that serves all of our associates and our providers, that provides counseling, mental health services, behavioral health assessments, mindfulness programming, and a 24/7 critical hotline for folks who are in crisis or for critical incidents that happen within the system. Our other structure is really the strategy and programming, and we spent some time, about 2 years, really building out best practice programs that now we can kind of pull down from that broad group. And we started with the crisis network programs, the critical incident programs, and are now building into the prevention space, because if you kind of go in with preventative programs when people are not in a great spot, it doesn't land well. And so we really needed to take care, particularly coming out of the pandemic and into current, we'll say, mental health concerns that are happening throughout the country. We knew we had to always have that safety net and really take care of those folks who were in a not great space before we could build in the preventative programs. And so some of the things that we do within those programmings include things like peer support. Suicide prevention is one of our newest tactics that we're rolling out for peers. We're all very comfortable in suicide assessments for our patients, but peer suicide prevention is a completely different ballgame. Even as a practicing family physician for 18 years, having that conversation with a peer is completely different. And so how do we embed those individuals who are really comfortable noticing and asking and escalating folks who might be in crisis? And really thinking about that anti-stigma approach and a lot of the advocacy work that you've heard about today. The state of Ohio has moved towards a safe haven, not just for the state medical board, but as of April, 14 of 16 of our healthcare licenses will be a safe haven approach. And we needed to respond to that as a healthcare system. And so how do we have the internal processes that mirror what folks are looking at when they're relicensing? We didn't want to have that conflict and dissonance when individuals were re-upping their license or were seeking help that they felt then the system didn't support them. So really looking at those internal processes. Now, all of this work came from a lot of different places within the organization, and we pulled resources from lots of different places. When the National Academy of Medicine called to action for accelerators, we were really excited to join that team because it reinforced that a long-term structure was needed. So what we really focused on throughout the last 18 months has been how do we create a structure that fits in our organization, that is aligned with how we move other work, so that we can continue to grow and iterate as we need to. So we've moved to what we call kind of a triad approach at Ohio Health, where there's a physician such as myself, I have a nurse, a leader as well, Christy McClure, and an operator, Heather Heron-Murphy, who hopefully you're watching. And we are kind of the triad approach of how we scale this work. So we fit in the organization in a way that people understand. When I say this is my operator, when we have our clinical leadership, we're able to kind of navigate throughout our organization, and we don't feel different and we don't feel disparate within our clinical enterprise. And having the basis of the National Academy of Medicine's structures have really allowed us to fit into the right places into the organization to make that work. We now have hospital-based well-being leaders who are able to take those best practices from that big umbrella and bring them down to the units so they make sense, because team well-being is not system well-being, individual well-being is not team well-being, as we all know, and are really looking now to iterate in those spaces, clinical informatics, working with our lean promotion office, and really thinking how we continue to grow our programs and make them make sense for where people are today. So it's a little bit about our journey, and appreciate the time.
Thanks so much for having me here today. I'm going to spend a few minutes talking about the way that we measure well-being within the organization and how we help people move to action. And I see my job as the Chief Wellness Officer is helping everyone see well-being as their job, not just my job. And our journey with measurement with well-being started back in 2016. I was recruited to the University of Utah late 2015, and we were immediately set to measuring and acting on initially physician well-being. And so we spent that first few months, late 15, early 16, looking at all the measures that we could possibly look at, debating back and forth about what we would choose, and we initially settled on the AMA Mini-Z item. We did our first round of surveys for school medicine faculty. The following year, our scope had expanded to everyone that works within U of U Health, so about 25,000 people. And we moved to the Stanford tool that year in 17. And it was great. We had little dashboards. We were kind of going to leaders and explaining results. And in 2018, we got completely shut down because the chief clinical leader at the time was worried that we might actually make people more burnt out by asking them about burnout. So, it was an interesting setback. We obviously disagreed with him. But it really made us think about how closely we were aligned with different groups across the system. And what we realized when we took a step back is that we had our survey and we really liked it and it was great. But then HR had a survey and the medical group had a survey and the DEI office had a survey. And all of us were doing our survey and then going around to the same leaders, talking about our results and what we thought action should look like within the organization. And it was at that moment of kind of setback that we really took a step back and said, well, what would be best for the organization? And at the time, I had had a lot of conversations with Steve Swenson, who talked a lot about the Mayo model of having a single survey. And so in that pivot year, we didn't get to do a survey in 18, But by 19, we were really leaning into partnering with different parts of the organizations to coalesce around less surveys, but more intervention. And so 2023, we finally got to the point where we were able to have a single survey for all the things. So if you wanted to understand climate, you wanted to think about HR, you were the medical group, you were in wellness, you were in the Office of Faculty. There's just one single survey that we all agreed upon, a lot of compromise there. But that not only do we do the survey together, but then we action the survey together as well. So when we think about that 2023, we use the Qualtrics EX25, which does use that single AMA Mini-Z item, which we'd been using for a number of years. Now when we show up to a college or school or a department, we can talk about the data collectively and think about what are the opportunities for next steps. So we use the Joy in Work model from the IHI. It's been a really helpful way to help people think about that plan, do, study, act, listen, sort, empower, improve model. And again, what's within my locus of control of an individual, my team's locus of control, and what's within the senior leader locus of control. And so within that model, we can say, okay, senior leaders, this is what senior leaders are doing this year to impact well-being within the organization. So for example, leave without being seen rate very high within our ED. What do we actually need to do system-wide to improve that? So we have a whole team of people thinking about, from the surgeons, from the inpatient clinicians, to the ED group, what are the actions that each of us can do to improve that leave without being seen problem? For example, in the hospital, we know that parking is a big issue. And you think, we could never do anything about parking, but actually we can. So we were able to think about having a lot very close to the hospital for people who are coming in at odd hours and not charging our lowest workers who were paying $20 an hour a huge fee for parking. That's a huge chunk of that salary. And so again, trying to sort out whose job is what, and then each year continuing to improve, being able to say, we heard you, this is what we're doing within the organization, and then to support teams who are leaning into this work with their own data. It is important to have data, but that is not the most important part. The most important part is how you operationalize that next step of what supports do you need to be successful. How do you approach a group who has low psychological safety, and how is that different from a group that has high psychological safety? What can that second group do by themselves that the first group really needs direct support in order to move the needle? And so I think with that, I will pause, and thanks so much for having me.
Hey, such a pleasure to be here. And I was going to say ditto to a lot of things that have already been said. I kind of want to start by just saying, just kind of reflecting on this journey that we've been on. My first meeting with the Clinician Wellbeing Collaborative was back in 2022. I do think of some of the major milestones. I do think of Dr. Lorna Breen and that story and the work of the foundation, so really want to thank you. And I think we've actually had some collaborations with your organization and the Los Angeles County Medical Association, so we thank you for coming out, speaking to our members. We advocate for 30,000 practicing physicians within the County of Los Angeles, larger than many states, in fact, with 10 million residents. So we've got a huge group of people that are trying to care for a very large population, and all the challenges are real. I remember back then, too, just the work that we were starting to hear about. How can we tackle prior authorization? What role will things like AI play? Workforce development, and when we think of things around diversity, equity, and inclusion, their implications on the workforce and burnout. So from 2022 to here we are today, it's been really exciting to see all of the progress that's been made, to see that we're at the second well-being day, to see that many of our organizations are now adopting these efforts and recommendations from the plan, our Bible, and many of us now have chief wellness officers. Many of our C-suites are taking these things very seriously. I'm proud to be a member of the American Medical Association that has the Joy in Practice recognition. See many of my colleagues taking pride in being at organizations that take clinician well-being very seriously. So we've come a very, very, very long way. What excited me and brought me to this work, honestly, was I work at Kedron Community Health Center, which is a historically black institution and an acute psychiatric hospital and federally qualified health center in South LA. I'm also faculty in family medicine and psychiatry at the Charles Drew University, which is our nation's 4th historically black medical school. We're in the poorest part of LA, and we serve a completely neglected and forgotten population, migrant workers, and underrepresented communities, black and brown communities in LA, those living with homelessness, substance use, living with HIV, serious mental illness, those that are justice institutional involved. So one thing that brought me to this work was I felt that we disproportionately bore the burden of trying to keep a system going, and yet I felt our workforce was disproportionately harmed by all the challenges we were facing, much higher rates of burnout, much less likely for us to be able to recruit and retain. And so there was a part of me that was very skeptical. Do these kind of plans only work for large academic medical centers, or are these things that where the vast majority of health professionals work in community-based facilities, hospitals, mom and pop, and all sorts of multi-specialty private group practices, right? When we think of all the places people get care, does this touch those folks too? And that was really important, and that really brought me to this table. What I've learned and our experience at Kedron has been, our timeline had to be very different, I felt, from the timeline that we were put on. And so I think that's one lesson I'm going to take away, that we all need to really be realistic about the environment that we're in, the realities on the ground, the leadership, the buy-in we have, and based on that, for us it took about 6 to 9 months well into the project for us to ever have a sit down with human resources and really make sure that they all had copies of this and they understood why we were taking this seriously. That's another take-home message, is that every leader within our hospital and that are involved within the teaching of our students and residents, we're the teaching hospital for Charles Drew, have this book. And I make sure that they have a hard copy of it, and I expect to see it in their desk or on their shelf when I come to their offices, whether it's the CEO, the business folks, the COO, and the CFO that often do step in the way of the work that we're trying to do, and for good reason, because they have their pressures, right? And we're answering to board. But we also have to figure out how do we bring the CMO and the CNO to that table also, and also the quality and the patient safety advocates and officers. So that was a huge part of us becoming, honestly, accelerating from we had no momentum to a place where I'm proud to say we are now moving in the right direction. And so I think being respectful and mindful of organizations are going to be coming to this work from very, very, very different places, and that's okay, and we still need to encourage it, because even the folks that are not the well-funded, the very large quaternary academic medical center still needs this work desperately, especially as ours is the least served community, for example, in LA. I will say, because of this work too, we had to think about what can we truly prioritize within this plan that was realistic given all the limitations. And for us, I did feel workforce development. Can I help upskill folks? People felt they were in dead-end jobs going nowhere, working in the poor ghetto, right? And so how do we get people to think about their professions differently, how to take joy in their practice, whatever role you're playing, whether you're the front desk or the medical assistant, throughout the whole system. We always talk about from the housekeeping to our CEO and everyone in between. And for me, I always prioritize those that touch and see and heal patients. And so for me, I also wanted to see how can we invest in them, the people that were actually delivering the care. And I think one thing that we learned was that a lot of folks who are in the system would like to be more helpful or to be able to touch patients, but they don't always have the opportunity or the skills. They don't feel like they have autonomy, agency, any sort of ability to make these decisions. So could we work, for example, we focused on Chapter 7 around workforce development. How do we help upskill, train? How do we retain? How do we recruit folks, specifically with that lens on justice, on health equity, on diversifying the healthcare workforce, on inclusivity? And so we ended up because of this work, we were able to write a grant and approached the Cedars-Sinai Foundation Community Benefits Office and was awarded a $400,000 grant that allowed us to upskill, train 25 people within this system. So we have about 600 employees. And one of my missions was, how can we move some of the folks that were non-clinical into clinical roles so they can feel the power of touching people and patients, And I also wanted the C-suite to see how important that aspect was and remind them that while y'all sit in your offices, the work is happening here. And so the realities, the struggles, the front line, I need you to come with us and see that. And so just the way I'm talking to you about that is how we needed to talk to our CEO, to our HR, but also to empower that receptionist that you can be an MA or a phlebotomist or an EKG tech if you want, and our hospital's happy to pay for it through this grant, and then therefore hire you in those roles. And it was very exciting to see folks transforming from non-clinical roles to now being able to wear both hats, which to us I think ultimately was really important. To better understand this problem, we all really needed to see what each other were going through, and so the folks not seeing patients needed to start seeing patients, and people that were only seeing patients needed to understand the hurdles the non-clinical folks were facing to keep the lights on and to continue to provide the care that we need to for our patients. So now here we are. We're like in our second year as accelerators, I think. I'm really excited to see how far we've gone. From the very beginning, it felt like the implementation of electronic health workers, beating our heads against Vision Sync and trying to figure out how to get our data into these things, how to work with the team at the National Academy of Medicine and Bram and all the amazing folks, Farida, who've really held our hands and the coaches along the way. There was a part of me throughout all of it that there was a small voice in the back of my head that said, trust the process, kind of how we had to with our electronic health records. And so now that we've gotten there, it was really this amazing opportunity of trying to map up what are we really doing, what are we really, the work that's happening, how do we truly capture it with these proxies that I need to somehow, for the sake of On and the team, get it in there every quarter, and figuring out the ways to meet those demands, but also realize it's actually very important work. And now looking back, it really did help drive the momentum, and now we have secured another grant with Cedars-Sinai for another $400,000 to really explore what more can we do in investing in the workforce. But now I do feel it is mainstream. Now it's not wellness in a corner. I do worry. We've made some really amazing baby steps, and the little ball has now become a snowball that could, turn into an avalanche one day, but I am worried about the huge steps backwards that we're taking, the financial pressures we're under. So a lot of what we've built, I do feel is under attack in the next 3 years. So I think the investment like this particular grant is going to be huge, really framing this differently and not wellness in a corner, but truly quality and patient safety. This truly is the business case, finance and operations. This really is an HR crisis, and ultimately, this is what the people and the population demand. And as a public health crisis, workforce burnout was really huge. And the last thing I'll just say, I've been so inspired by the work, not only at Lorna Breen, but by the researchers that a lot of the plan was built off of, whether it's Tate Shannonfeld, when I think of Dr. Krasinski at the AMA, when I think of Maslow's burnout inventory. I always thought those were just lofty things that sat up on academics' shelves, but to really feel the impact of that academic work on the front lines at a poor ghetto hospital in South LA really does mean a lot to us. So thank you so much, and we're really excited to be a part of this program.
Thank you so much, Lori and Amy and Jerry, for sharing your boots on the ground experiences and lessons learned in these Accelerator lightning rounds. You can see, I hope, why I feel so energized and invigorated and hopeful after our monthly meetings, and I hope that you all feel that way after their presentation today. Thank you so much.